Good afternoon. I'm Javier Louro. I'm from the Hospital del Mar Medical Research Institute, which is based in Barcelona. And this work is a collaboration between my center and the BreastScreen Norway, which is the national screening program in Norway. It's part of my PhD that I did last year, but due to COVID, we have to delay the collaboration. And finally, this work is going to be ended later than my PhD. So briefly, this work, to put you all a little bit in context, is in order to improve the risk-benefit balance of breast cancer screening that has been a little bit controversial last years. Some studies in the last decade have proposed personalized screening strategies based on each woman's individual breast cancer risk. So for this reason, in 2019, there was a group of experts in a European Conference on Personalized Early Detection and Prevention, was called Envision in Austria, which stated that there was a need in Europe to develop breast cancer risk prediction models based on data from large screening cohorts and including risk factors that were easily obtainable at screening participation. So in this context, the main aim of this collaboration was to develop a breast cancer risk prediction model with information of women attending this BreastScreen Norway, the screening program of Norway, in order to have a tool to identify which are at a lower risk and to personalize the breast cancer screening. So we use information of 57,000 of women that were screened in 4 counties of BreastScreen Norway, the 4 counties that had systematically collected information on breast density between 2007 and 2019, and we follow up them to early 2022 to have 2 years of follow-up. So this screening program, the BreastScreen Norway, is a well-established program with 76% participation, which is more than the considered high by the European guidelines. We had a total of 180,000 mammograms of these women. And so we use a statistical model that is called partly conditional Cox regression model to obtain the adjusted hazard ratios of the different risk factors. We finally identified age, body mass index, mammographic density, family history of breast cancer, benign breast disease, alcohol intake, and hormone replacement therapy as factors that confer a higher risk of breast cancer, and age at menarche, exercise, and pregnancy as protective factors. And with all these factors, we create this mathematical tool that more or less calculate the 4-year risk of developing a breast cancer of a woman based on her individual characteristics. Then we use it in our cohort to see more or less how was the distribution of this risk. We found that the risk varied between 0.2%, which is really low, to a 7.4%, which is really high. That shows us that there are real differences between the risk of all these women. And the quartiles were 0.8, 1.1, 1.4. Then we use a validation methodology that is called bootstrap methodology with 1,000 resamples to estimate 2 validation statistics to the model, which are the expected observed ratio and the area under the ROC curve. The expected observed ratio was 1.1, so it showed that the model slightly overestimated the risk, but it was a really good calibration of the model. And the area under the ROC curve was 63%, which is kind of similar of all the models that are being used in breast cancer, because in breast cancer, the area under the ROC curve is always low because it's hard to predict which woman. We have to remember that these are asymptomatic women. It's hard to predict which one are going to develop a breast cancer in 4 years and which don't. Then we plot the effect of each variable to see which one had a higher effect in the model. We found that breast density was the one that had a higher effect. But all of them had somehow some effect. More or less that was all. Now we have the tool. So more or less the conclusion of this work is that we created, and we validated this risk prediction model that can be used to estimate the breast cancer risk in every woman participating in BreastScreen Norway. If we want to use it in another context, we should have to calibrate it with the incidence of the other contexts, but we designed it just for Norway. And this model can be key in the future for designing risk-based personalized strategies in order to improve this risk-benefit balance of breast cancer screening. I think this study for just itself doesn't change what is the paradigm right now of breast cancer screening, but it's important to take it into account to the future because I mean right now to move from the actual breast cancer screening to the personalized screening strategies is important, but we have to do it carefully because it has an impact like an ethical issue because you are going to offer the woman in low risk less screening than the woman in high risk, and this can have consequences. So we have to be sure that these women are effectively at a low risk and that is effective, that improve the effectiveness of screening. But there are some clinical trials right now, at least Wisdom in United States and MyPeps in Europe, which we are working with, that are going to in the following years prove that screening strategies are effectively more that improve the effectiveness of breast cancer screening. So in that moment that we are sure that we can implement these personalized screening strategies, I think this model as is the first one that is developed just with Norwegian court, and it has I think a robust methodology and good information. It can be used. It can be the one that is used in Norway to do so to estimate the risk of each woman.